Okay, so we can start again. So I'm just gonna answer quickly some of the questions that you ask. So you were saying you were questioning about what's the difference between the didelphys and bicornuate. So as I told you before, the case of the didelphys uterus that we talked about, you have two separate endometrial cavities that are not communicating with each other. So if they're not communicating, it cannot be bicornuate. It should be didelphys regardless if you have a single cervix or two cervices. There is another question was asking about, is there a specific measurement we could use deciding a small uterus? No, there is no specific measurement. But if you see the uterus is deviated toward one side, this means that it is an abnormal uterus. Another question was asking about if they have an intact lower third of the vagina, is it an MRKH syndrome? So MRKH syndrome, it's a spectrum. You can have hypoplastic uterus, you can have aplastic uterus, you can have a hypoplastic vagina or absence vagina. So any of these, it is still called as MRKH syndrome. So we finished this part, guys. I'm gonna move into imaging of malignant gynecological disease. So I'm gonna talk mainly about cervical, and then we'll move into endometrial, and then if we have time, we can talk about ovarian malignant lesions. So whenever we are talking about uterine malignancy, we always prefer to use the MRI. The reason for that is we know that CT has its own limitation in assessment of the uterus, and ultrasound is not good for assessment of staging. It is usually used for the initial imaging of any uterine or cervical abnormality or ovarian abnormality, but for better evaluation and better staging, we usually use the MRI. So it is very good for preoperative planning and risk stratification. The protocol of MRI of gynae disease is extremely important. A lot of time I get and I receive CD from other places to look at MRI, and sometimes they're very difficult to interpret, and sometimes it's very difficult to give an accurate staging if you don't have the correct protocol. So what I always like to have is my T2 high resolution sequences are my money sequences. I cannot give good staging without the three planes of the T2 sequence. Sometimes I ask them for a T2 coronal large field of view if I want to look for a retroperitoneal lymph node. I ask for T1 axial images just to be sure about presence of any fat content within the lesion, presence of any hemorrhagic component. You have to have your T1 fat saturated sequence because, as I said, if there is a fat content, you want to look for any fat suppression. If there is a hemorrhagic contents, you want to look for any hemorrhagic contents. And then you have the pre and the post contrast high resolution fat saturated sequence. We commonly do the diffusion weighted sequences, especially and extremely helpful in cases of ovarian lesions. So we move into the first part of malignant of gynae malignancy. So I'm going to talk about cervical cancer. So theoretical part of cervical cancer is you have to know that cervical cancer is originating from the squamocolumnar junction of the cervix, and that's why 70% of the cases of cervical cancer, it is usually squamous, and 25 to 24% about adenocarcinoma. So usually, whenever I see a cervical mass, I suspect that it will be squamous. When I see the pathology coming back as an adenocarcinoma, question yourself, is this a possibility that it could be an endometrial cancer going into the cervix? Because endometrial cancer tend to be adenocarcinoma, but cervical adenocarcinoma can happen. And then you have other rare types of malignancy seen elsewhere. So the way we stage cervical cancer is with FIGO staging. It was updated recently in 2018. However, the way that cervical cancer is staged, it is clinical staging. So the FIGO staging of cervical cancer, it is clinical staging. We use MRI because MRI is accurate, is more accurate than the clinical staging. And it's very helpful for the surgeon in planning their managements. So on the previous FIGO staging, the one before 2018, lymph nodes were not part of the staging, but they were important factor to know because it does change the management. In the recent staging that was done in 2018, lymph nodes now are part of the staging and it is incorporated into the staging. So just to keep in mind, MRI staging of cervical cancer is extremely, extremely accurate. So this is the article that I would refer you to go and look at about the FIGO staging of cervical cancer. And I have that hand on my office for reference whenever I need. So whenever you look here, these just circling the areas that you have to look about, and these are the areas that you have to keep in mind. Whenever you have a stage, a mass in the cervix that is measuring more than 4 centimeters, this is important. Why? Because the staging will be 1B3. However, because the lesion is more than 4 centimeters, it will be non-surgical. The patient will go for radiotherapy. So keep in mind, size of the cervical mass is important because it does change the management. So anything bigger than 4 centimeters, it is considered stage 2A2. Another important stage that you always keep in mind is the one we call 2B. So we always say in cervical cancer, to be or not to be. What does it mean? 2B, when there is a parametrial invasion. You remember the image that I showed you with the parametrial fat surrounding the area of the cervix, high signal intensity. If that parametrial fat is involved, then you are dealing with stage 2B. If we have lymph node involvement, you remember I told you before, lymph node on the previous staging were not incorporated into the staging. But now, if you have lymph node involvement, it will be stage 3. Depending on the level of the lymph node involvement, is it involving pelvic lymph node or para-aortic lymph node? It is indicating stage 3, either C1 or C2. So if we go back here, just let me give you this. This is the image that I showed you before. You have the endocervical gland. You have the low signal intensity cervical stroma. If you look here, this is the area where cervical stromal invasion is very important. And this is your outer cervical ring, where if the mass is invading all of that and going outside, it does indicate that there is a parametrial invasion. So just a second. So if I go back here, so this is just a case. So I will show you a few cases of cervical cancer. So you look at these different images, and when you see here, if we go back into stage 1, you have an invasive carcinoma. However, you're looking at the depth of the invasion into the cervix. So stage 1A, you're talking about a very small cancer that probably you will not be able to see, and it is usually diagnosed by biopsy. When you have a cancer that is bigger than 4 centimeter in size, it is stage 1B. If this cancer is less than 4 centimeter, between 2 and 4, then you are dealing with stage 1B. So let's go back here. Here you have what looks like completely normal uterus. You have a normal endometrium, you have a normal endocervical gland, you have a normal stroma, there's nothing. So this I can't call anything. So, but if the pathology comes back positive, then we're dealing with stage 1A. Stage 1B, when you have a cancer, however, when you look at it, you remember here 1B and 1B1 and 1B2. If it's 1B2, this cancer is between 2 and 4 centimeter, very important. So obviously, I have to look, you have an enlarged uterus and you have a mass. What is the epicenter of the uterus? You remember the first step we said we decide, is it uterine versus extrauterine? So I know it is uterine. Now your next question, is it uterine or cervical? The epicenter of the lesion is really within the cervix. So where is it coming from? Your next question, is it coming from the endocervical gland or the stroma? So you can see that I don't identify the stroma very well, and it's mainly, it is occupying the endocervical canal. So most likely I am dealing with a cervical cancer. You do your measurement, and based on this, your stage is 1B2. Don't forget, whenever we look at the cases, we look at the cervical stromal invasion, into parametrial invasion, into urinary bladder invasion, rectal invasion. But this is just your initial step. So this is just another case. So if you're looking here, this is a cross-sectional images of the cervix. Again, I told you before, you have to look at your junctional normal zonal anatomy. At the level of the cervix, we said normally we have high signal intensity central endocervical gland surrounded by a low signal intensity ring cervical stroma, surrounded by an outer ring of cervical stroma outside. So when you look here, you can identify that there is an intermediate signal intensity lesion replacing the area of high signal intensity endocervical gland. And actually, I cannot see a full ring of cervical stroma. So I would question, am I having something there? Is there something invading into the cervical stroma? Diffusion weighted sequences are extremely helpful when you have question. So as you can see here, you have mild diffusion restriction on diffusion weighted sequence. You have a high signal intensity with corresponding low signal intensity on ADC, appearance in keeping with diffusion restriction. And when you look at the post-GAD enhancement, you can see that the mass is hypovascular. And this is what we expect to see in cases of cancer. This is just another case. So I want you just to understand and remember what a normal anatomy looks like. So let me make this bigger for you so you can see it better. So you look here again, we will review the anatomy. High signal intensity T2 endometrium, low signal intensity junctional zone, slightly intermediate signal intensity outer myometrium, and then the endometrial gland is continuous with the endocervix. The lower part of the endocervix, if you look, you see that it is replaced with an intermediate to low signal intensity area, and it's actually creeping and going into the endovaginal recesses and the anterior and the posterior vagina. The long axis image, you can see that there are some Nabothean cysts. However, this area corresponding to this area, this is abnormal. Look carefully at the cervical stroma and the vaginal fornices. They are all intact. So whatever malignancy is happening here, it is still confined within the endocervical gland with no evidence of invasion. Okay, if we move into stage 3 is very important because it means that we're dealing with a non-surgical case. It indicates that there is invasion beyond the uterus. To call it invasion into the upper 2/3 of the vagina, it is considered 2A. If it is invading, sorry, I'm talking about stage 2, not stage 3, guys. So stage 2 is the one we said that it is very important to change the management. To be or not to be? If it's 2B, it means it's non-surgical. If it is less than 2B, it means it is surgical. What's the definition of stage 2? The definition of stage 2 is when the cancer invades beyond the uterus, however, did not extend into the lower third of the vagina or the pelvic side wall. If it extends into the lower third of the vagina or pelvic side wall, then I'm dealing with stage 3. So, involvement of the upper 2/3 of the vagina is 2A. Involvement of the parametrium is 2B. The way I remember it is B and B. So B and P, parametrium. So 2B and 2B. 2A is the upper third of the vagina. So let's look at this case. So if we look at this case, we have an enlarged uterus. You have your endometrium that looks okay. And then you have the area of the cervix that is enlarged. You have the anterior myometrium is asymmetrically enlarged with a focal low signal intensity mass. So the appearance of this is suggestive of fibroids. There's not much differential diagnosis identified. And then when you look at the cervix, you see that you have the endocervical gland signal intensity that I told you before. Usually it is high signal intensity. It is completely replaced by intermediate to low signal intensity. And it is filling the area of the endocervix. You see that it is extending into the area of the upper third of the vagina. It is filling the anterior vaginal fornix. So here, I want to be sure it is invading the upper third of the vagina or not. And when we talk about invasion of the upper third, it does not mean filling the vagina. It means that it is invading the mucosa of the vagina. And this would be better assessed when you look at post-gadolinium imaging. This is just another case. However, this one showed possible involvement of the vagina. However, you don't see extension into the surrounding fat. This is another case where you have invasion into the parametrium. Why did I call parametrium invasion? There are two important things that I can identify on this image. At the level of the cervix, you have an intermediate signal intensity mass filling the endocervical canal. You remember the area of low signal intensity cervical stroma that I told you always have to find all over the cervix? You see that it is very thin in this part, and you have areas of interruption of the stroma with similar signal intensity tissue seen extending into the adjacent tissue. You have similar finding along the posterior aspect. So when I see these findings, I know that most likely I am dealing with areas of stage 2B with parametrial invasion. Stage 3 is the changes that happened recently in the new staging. And when you see it, you have involvement of pelvic and para-aortic lymph node, regardless of the size of the tumor or the involvement. So in this case, for example, you have a huge finding. You have a large mass involving the cervix. It is extending into the cervical stroma. It is involving the parametrium. It is invading into the urethra. It is invading into the urinary bladder. So this is sort of presence of pelvic lymph. This is actually stage 3 up to stage 4 because of the surrounding. So stage 4 is when you have rectal or bladder mucosal involvement. And I just want to point out, be sure that we are talking about mucosal invasion and we're not talking about bladder wall invasion. Stage 4A or B, 4A when you have rectal or bladder invasion, stage 4B when you have spread to distant organ or organ metastasis. So we finished the staging. I showed you a few cases of cervical cancer. I showed you how to look for cervical stroma invasion. I showed you how to look for parametrial invasion. I showed you how to look for adjacent organ invasion. What are the prognostic factors that would make difference in the management of these patients? There are three important prognostic factors that you keep in mind. Tumor size. What is the tumor size that make a difference in cervical cancer? We mentioned it. It's the 4 centimeter. Anything above 4 centimeter is very important because the patient will be non-surgical. Parametrial invasion is another case because patient will be non-surgical. Lymph node involvement is another prognostic factor because this patient, she will need a chemotherapy as well. So tumor size is very important because the physician usually they are able to measure the tumor size. However, the clinical estimation of the size of the tumor is very poor. And the reason for that is because when they measure the size, they usually measure the mediolateral and the AP dimension of the tumor. They are unable to measure the craniocaudal dimension of the lesion. So when we do our MR assessment, sometimes we give them a larger size because we are able to assess the craniocaudal dimension of the tumor and they are unable to do so. So as I said before, large tumor size more than 4 centimeter will be treated with radiation therapy. So for example, this case, this patient was referred for MR staging. So the physician will be able to measure the size anterior, posterior, and medial to lateral. However, the craniocaudal extension, they will not be able to see. They will just feel this part. So that's why this is the tip of iceberg. Sometimes they measure like 2 centimeter and the size of the mass itself in a craniocaudal dimension can be 6 or 8 centimeter. And that's why MRI is very accurate in assessment the size of the tumor. Parametrial invasion is another important area that we look for. So look for periuterine connective tissue and the fat. Your criteria is loss of low signal intensity cervical stroma, frank tissue invasion where you see similar tissue seen in the fat, and if you see similar tissue encasing the uterine vessels. Your best sequence for assessment of parametrial invasion is the short axis. So I usually ask the technician whenever I have a case of cervical cancer, I tell them don't forget to take short axis. I don't want short axis of the uterus. I want short axis of the cervix to look for parametrial invasion. So if you look, this case is very similar to the other case. You see cervical lesion, you have the cervical stroma ring, you have some interruption, so you might suspect that there is a parametrial invasion. However, I don't see frank tissue extension into the parametrium. So this case, it could be easily stage 2B cervical cancer. Again, look at this case. This is a good case. So you have a cervical lesion, you have a continuous preserved low signal intensity cervical stroma. When you compare it to this case, you see that you have a mass, you have a preserved cervical stroma from 12 to 6 o'clock in clockwise rotation. However, the rest is interrupted with frank tissue invasion in keeping with parametrial invasion. So lymph node involvement, we said part of FIGO staging now. The nodal definition of the size is more than 1 centimeter. However, sometimes I use the diffusion weighted sequence signal intensity and the signal intensity on T2 sequences for better assessment and better suspicious of involvement of the lymph node. PET-CT is the best modality for evaluation of malignant lymph node in cases is needed. Just a quick theoretical information about endometrial cancer. So now we finished cervical cancer. I'm gonna move into endometrial cancer, guys. So you remember we talked about cervical cancer, 75%, it is squamous, 25%, it is adenocarcinoma. The opposite to that is the endometrial cancer. So endometrial cancer, there are two types. Type 1 usually is the better type. 90% of the cases, it is adenocarcinoma. Usually, it is less aggressive. Histopathology grading, usually it is grade 1 and grade 2, has better prognosis and infrequent lymph node involvement. So this is type 1. Type 2 is the less common type, representing 10%. Usually could be clear cell or serous papillary. I will show you a few cases like that. It's usually very aggressive. Usually by pathology, it has grade 3 and it has a worse prognosis. So this is theory, important for you to memorize. The traditional treatment and management of endometrial cancer, it is usually hysterectomy and bilateral salpingioropectomy with lymph node dissection. How do we stage endometrial cancer? Endometrial cancer, again, it is by clinical staging. What do we mean by clinical staging or histopathological staging? It means that patients should go for hysterectomy, bilateral salpingioropectomy, and lymph node dissection, and after the pathology, they will tell me exactly what is the final staging. So, what is the role of MRI? There is no survival benefit of lymphadenectomy for low-risk disease, stage 1, grade 2. What does that mean? So, whenever I do my MRI assessment, the MR assessment, it does help in assessment of the invasion of the inner or the outer myometrium. It does help in the focal and local staging. Whenever I tell them stage 1A, for example, which means just invasion of the inner myometrium, the risk of lymph node involvement is significantly low. So at that point, if I tell them that patient stage 1A and clinically, the patient is a high-risk patient, meaning that she has multiple comorbidities, they probably can do only hysterectomy and bilateral salpingioropectomy and avoid doing the retroperitoneal lymph node dissection because of the higher mortality of that. So in some cases, where the patient has multiple comorbidities and she is considered as a high-risk patient, MRI can help them to avoid doing the lymph node dissection. However, I want you just to keep in mind, guys, that NCCN guidelines recommend lymphadenectomy for all stages. So if you have a healthy patient coming with stage 1A with no comorbidities, it is recommended to go for lymph node dissection and retroperitoneal lymph node dissection to get the accurate staging of the cancer. So the MRI is very helpful, as I told you, to predict the depth of myometrial invasion. So we can tell what is the probability for lymph node involvement, and we can identify patients who can benefit from conservative therapy. What does that mean? It means that sometimes we get patients who are young, premenopausal, with endometrial cancer, and they have no kids yet. So these patients, and they're a very small percent of the patient, if they are stage 1A, very early stage, they can go for medical treatment of endometrial cancer with careful follow-up, so they don't have to go for hysterectomy or bilateral salpingioropectomy. So sometimes MRI is very helpful in management of these patients. Again, endometrial cancer staging has been changed in 2018 and we have the new staging. I would refer you to go to this study and look at the staging. So if we look, I have a copy of this in my office again. So the stage that I always see is stage 1. So looking at this, 1A, there is no or less than half myometrial invasion. 1B, there is invasion to more than half of the myometrium. In the old staging, we had to have A, B, and C. So now it's only A and B. When I have 1A and the patient has multiple comorbidities and I tell them with MRI, then they can go for hysterectomy without retroperitoneal lymph node dissection. Stage 2, when you have invasion of the stroma but does not extend into the outside the uterus. Stage 3, you have A, B, and C. A, when you have invasion into the adnexia or the serosa. B, when you have vaginal involvement or parametrial involvement. C, when you have pelvic lymph node invasion. 4, very similar to the cervix. A, when you have invasion into the bladder or the bowel. B, when you have distance metastasis. So if we look at stage 1, so this is the one that is commonly seen, 1A and 1B, our outer or inner myometrium. So this is a good case. So you look here, this is a mid-sagittal image, and this is your best sequence to look for endometrial abnormality. You remember I told you the endometrium is usually bright signal intensity on T2. In this case, it is completely replaced by low signal intensity T2 mass. On post-gadolinium injection sequences, you see that the lesion is hypoenhancing in comparison to the rest of the myometrium. My next step, I want to see, is this mass extending into outer or inner myometrium? In this case, actually, there is no invasion into the myometrium. It is very confined to the endometrial cavity. So in this case, I am dealing with stage 1A. Stage 2, when it is invading into the cervical stroma, however, it is still confined to the uterus, as in this case. So here you see that the uterus is enlarged, the endometrial cavity is distended with some fluid. You have a mass, the epicenter. Sometimes you might struggle, where is this mass coming from? Is it from the uterus, from the myometrium, from the endometrium? So here it is coming from the endometrium invading into the outer myometrium. And if you look at the cervical region, there is invasion of the mass into the cervical region. So this is in keeping with stage 2 cervical cancer. Stage 3 is when you have lymph node involvement. This is just another case with significant involvement. So you see that endometrial cavity completely replaced by intermediate signal intensity. It is invading into the cervix. It is invading into the vagina. You see irregular shaggy appearance of the outer serosal surface of the uterus, suggestive of serosal involvement. So this is in keeping with stage 3 endometrial cancer. You might question why this is not cervical. I agree with you. Sometimes it is very difficult. The involvement can be predominantly cervix or uterine. So in this case, if I'm not sure, like if I think that this is primary cervical, I would stage it based on the cervix, and I would refer the patient for biopsy. Keep in mind, I always say that, but sometimes the patients come to us before. I always say, if the patient is a gynae malignancy cases, it's better to get pathology first before getting the MRI, because the pathology will help me to identify what's the primary. So for example, if this case is coming as squamous cancer, then most likely this is a primary cervical cancer with extension, and it doesn't matter. This means that it is already stage 3 because you have already retroperitoneal lymph node. So it is a case of advanced cervical cancer. You might tell me, I'm not sure. So some cases really, sometimes it's really difficult. This turns to be squamous. Squamous goes better with cervical. The epicenter of the lesion is mainly cervical rather than endometrial. So I would say that this is most likely cervical cancer. However, this is case, I know that it's endometrial because of the staining and because of the histopathology finding. They said this is most likely endometrial rather than cervical. So sometimes if you're not sure, you can stage it based on the epicenter. Is it coming from the cervix rather than the vagina? So this is, again, a case of cervical cancer. However, the difference is you see that the ovaries are abnormal with areas of tumor tissue identified along the surface of the ovary in keeping with stage 3C1 with local involvement. This is just another case, guys, but this is a typical case. So if you look here, you can see that the uterus is abnormal. It is significantly enlarged. You see that the endometrial cavity is distended with abnormal signal intensity. And if you look carefully, the myometrium itself is significantly abnormal as well. You look at the cervix, it's very similar signal intensity. So based on this, I would say that this is most likely endometrial cancer with invasion into the surrounding myometrium. Is there any other possible differential diagnosis? Is it possible to be arising from here and going into the endometrium? Yeah, this is another possibility. Could be coming from the myometrium with invasion into the endometrium, and it could be rather than sarcoma, rather than an adenocarcinoma. So I would still recommend biopsy. Look at the diffusion weighted, significant diffusion restriction. This is highly suspicious for underlying malignancy. Generally speaking, cancer of the uterus, cancer of the cervix, they tend to be hypovascular when we compare it to the rest of the uterus, and this is an important differentiating feature. So, what are the technique for evaluation of endometrial cancer? You remember we talked before about this technique for cervical cancer. We said the 3-plane T2 sequences are the best. You have to look for them. These are your many sequences. Post-contrast is generally speaking helpful for both cervical and endometrial cancer, especially to understand that they are usually hypovascular. So cancer are hypovascular, benign lesions tend to be hypervascular. If I want to give contrast in cases of endometrial cancer, your post-gadolinium injection sequences should be done on sagittal. Why? Because you remember we said your best sequence to look for inner or outer myometrial invasion is your sagittal sequence. And that's why I do my post-gadolinium injection sequence on sagittal imaging. Diffusion weighted sequences are usually very helpful in these cases. So, what is your take-home messages for endometrial cases or endometrial cancer? You want to look for the depth of myometrial invasion. So if you want to remember something for the exam, I want to check if there is inner or outer myometrial invasion, because this will predict the lymph node involvement. MRI is accurate for assessment of myometrial invasion, and it does help in stratifying ladies for lymph node dissection. So by that, we finish the endometrial cancer. We can have a quick look at ovarian cancer. So ovarian cancer, they're usually 90% epithelial type, most commonly serous versus mucinous. Clear cell and endometrioid type are less common. There are multiple other types, including germ cell, 6-cord stromal tumor sarcoma. However, they are uncommon as the epithelial malignancy. Primary mucinous are much less common. Mucinous metastases tend to happen more likely, and most serous carcinoma usually arises from the fallopian tube rather than the adnexia. What is the usual treatment for ovarian cancer? They usually go for staging laparotomy with complete debulking. What does it mean, debulking? Debulking means they will go for hysterectomy, bilateral, salpingio, or oropectomy, lymph node dissection, and resection of the omentum and the peritoneum. They might receive adjuvant chemotherapy. If the disease is significantly extensive, they might receive chemotherapy before the treatment or before the surgery, and then they go for surgery to do optimal reduction. What is the role of MRI in ovarian lesion? I'm not a big fan to do MRI for ovarian lesions. I like to do it only for not completely diagnosed ovarian masses, meaning that if I have a lesion that is complex cystic lesion with solid component, this doesn't need MRI. But if I have a solid lesion probably needs MRI for better characterization to know if I'm dealing with the benign versus malignant and the likelihood of malignancy. Peritoneal disease are best assessed by CT scan. However, MRI is extremely accurate using diffusion weight sequences to look for tiny peritoneal disease. Detection of lymph node, they are best done by CT scan. MRI can be used as well for that. What are the predictive imaging findings for malignancy? So we all know that presence of a solid mass, presence of papillary projection, presence of thick septation more than 3 millimeter, presence of vascularity within the solid mass or the papillary projection, and presence of enhancement within MRI. Other important findings that you have to look for: presence of ascites, peritoneal metastasis, lymphadenopathy, pelvic or organ invasion are all features of malignancy. So this is just a simple case. I think this is bread and butter of gynae disease, very easy. You have a pelvic solid complex cystic lesion in the pelvis. The first step, as I told you before, you want to be sure that this mass is arising from the uterus or the ovaries. So your next step is, you can see that the uterus is here. This is most likely arising from the left adnexia because it has the close sign. It is predominantly cystic with some solid component. Post-gadolinium injection sequence, you see that there is enhancement of the solid component. So this is most likely in keeping with malignant epithelial ovarian neoplasm. You always want to check the other ovary. You want to be sure that there is no retroperitoneal lymph nodes. You want to check that there is no peritoneal carcinomatosis, and you want to check that there is no malignancy elsewhere. And then I would correlate with tumor marker of the ovaries, refer the patient for gynecology consultation for surgical resection. This is just another case. So when you look at this, you can see that there is a huge pelvic-abdominal complex lesion. It is really predominantly solid. It has some areas of necrosis. As we said before, you want to see where is this mass coming from. Is it mesenteric? Is it retroperitoneal? Is it pelvic? Is it adnexial? Is it uterine? So the way is you can follow the ovarian vein. If it is involving and going and inserting to that mass, then most likely adnexia. So if I'm saying that this is mostly solid adnexia lesion, you have differential diagnosis. What is your differential diagnosis? I would think about metastasis to the ovaries from elsewhere. You can see that there is a lymph node, there is a mass here in the peritoneum, so there is peritoneal carcinomatosis. So what's your differential diagnosis? Differential diagnosis of solid ovarian lesion would include metastasis, less likely primary ovarian. Other possible differential would include 6-cord tumor, granulosa cell tumor, or Brenner's disease. However, usually Brenner's, they come in a smaller size. You look carefully here, and then you can see that there is soft tissue mass along the surface of the liver. So I know that this patient has extensive peritoneal carcinomatosis. This is just another similar case. You have bilateral adnexial lesions. Are they solid or cystic? This is what we call a complex cystic lesion because it has some solid component and it has a cystic lesion. When we say the differential diagnosis for a complex cystic lesion is different. If I'm talking about a complex cystic lesion, I would put primary malignant epithelial ovarian neoplasm first, and then I put metastasis. In contrary to that, the case that we just saw here, if I see predominantly solid lesion, no, I would put metastasis first and less likely primary epithelial ovarian neoplasm. This case, if you look carefully, you have large amount of ascites. So you have multiple areas of peritoneal nodules and carcinomatosis. You look here, there is another peritoneal carcinomatosis. You have a complex solid cystic lesion on the right side. So when I show you these findings, it's not just to identify, because these represents the important positive and the important negative that you have to think about when you are faced with a gynae case. So whenever I am dealing with a regardless solid or complex cystic lesion or a uterine or a cervical lesion, these are your important negative. So I will always talk about retroperitoneal lymph node. I will always talk about ascites. I will always talk about peritoneal carcinomatosis, because at the end, this will give the final conclusion. So in this case, you look, you see ascites, and I would question that there might be something in the right breast. So if you have a complex cystic lesion, probably metastasis would go first. This is just another ultrasound case. So if you look here carefully and make it a little bit bigger. So here you have to decide what is this coming. So this is a pelvic lesion occupying the pelvis. I have to decide, I have to identify, is this coming from the uterus or the adnexial? So if you follow the adnexial vein and you see that it is adnexial, you have to decide, are you dealing with solid or cystic? So this is a predominantly heterogeneous solid lesion with tiny cystic changes, mild posterior caustic enhancement, you have some vascularity. So based on this differential diagnosis of a solid adnexial lesion, I would think about metastasis, I would think about Brenner tumor, I would think about granulosa cell tumor. Is fibroma is a possibility? It is a possibility. However, the appearance on ultrasound is not like that. Fibroma usually hypoechoic, it's not hyperechoic, and usually have posterior or caustic shadowing. So based on the ultrasound, fibroma is much less likely. I would go ahead and do the MRI imaging of this case. So when you look at the MR, this is arising from the adnexia. So it is predominantly solid. It has some cystic changes. If you look carefully on T1 on T1 out of phase, there are foci of high signal intensity. There is a component of blood within this lesion. On post-gadolinium injection sequences, you can see that there is multiple area of solid component and cystic changes. So this, if I combine the finding from ultrasound and MRI, I was looking at what looks like a solid lesion with some cystic changes, and it does have some hemorrhagic component. So the lesion that can give all of these features is a granulosa cell tumor, because it tends to be hemorrhagic and solid, strongly enhancing. This is just another case. So if you're looking here, we see again there is a midline mass. You have to identify where is this mass coming from. So I would question, this is the uterus? So if this is the uterus, this is probably an adnexial lesion. Next question, is it solid or cystic? Looking at it, it looks like solid with some cystic changes. Your differential diagnosis for solid lesion would include metastasis, granulosa cell tumor, fibroma, Brenner tumor. Your next step, you would do MRI or CT scan. When you look at this case, you can see that there is large amount of ascites. There's areas of peritoneal nodularity, peritoneal carcinomatosis, predominantly solid lesion in the pelvis. So my differential number one would be metastasis versus other differential diagnosis. I would correlate with the tumor marker of the patient. I would ask for mammogram of the patient, and I would check the colon, the stomach, pancreas to be sure that there is no primary. We did an MRI image of this patient. Again, you see that you have a solid lesion, heterogeneous areas of blood component within the lesion, and the lesion was was actually strongly enhancing, but they don't have the enhancement here, and this turned to be again as a granulosa cell tumor. This is just another case where you have ascites, you have some solid component. However, this solid component had some fat content. You look at the pelvis and you see that you have bilateral adnexial complex lesion. They are predominantly solid. They have foci of calcification. They have foci of fat within them. So the appearance of this is very suspicious for malignancy. What kind of malignancy? It is not dermoid, it's the malignant dermoid. It's the malignant form of the fat-containing lesion, germ cell tumor of the ovaries, and this should go for chemotherapy. So, what are the important things that you always have to check for malignant ovarian lesion? The signal intensity of the lesion is extremely important. Look for any blood component, look for fat and blood. So if you have fat, think about dermoid or the malignant form of dermoid. If you have blood, think about the granulosa or hemorrhagic metastasis. If you have low signal intensity, think about fibroma or fibrothecoma. If you have intermediate signal intensity on T2, think about METS, lymphoma, and again, granulosa cell tumor. This is just a quick example for cases. So when you look at this, you have a left adnexial lesion. The difference between this one and the one that I showed you before, it demonstrated predominant low signal intensity on T1. It could have diffusion restriction, or there might be no diffusion restriction. It depends. It could have mild or moderate enhancement, but because of the signal intensity on T2, the appearance is suggestive of fibroma. So look here, there is mild diffusion restriction. I have to tell you that fibroma has a spectrum of the diffusion restriction. It could have completely normal diffusion, or it could have significant diffusion restriction. So diffusion does not help in identifying fibroma from any other differential diagnosis. Again, enhancement is very valuable. If the fibroma is predominantly fibrous tissue, it will have mild enhancement. If it has more of a thecoma component, you will see more enhancement on post-gadolinium injection sequences. So this is just a last case again. If you look carefully, you have a pelvic lesion. Your next question is, where is this coming from? It is separate from the uterus. It is most likely arising from the right adnexia. It demonstrated intermediate signal intensity on T2. It showed significant diffusion restriction, and on post-GAD, it showed significant enhancement. And this patient is 15 years old. So when you see solid adnexia lesion, it is intermediate, so it's not a fibroma. It shouldn't be metastasis, unlikely to be metastasis. It doesn't look like granulosa cell tumor, and it's unlikely to be Brenner. So keep in mind that at this age, we tend to see germ cell tumor. So you want to correlate with the level of beta HCG, alpha fetoprotein, because this term to be this germinoma. So this is your approach for adnexial or ovarian lesion. Whenever you have a solid lesion in the pelvis, where is this lesion coming from? Is it uterine, cervical, pelvic, or ovarian? Once you identify the origin, go through the differential diagnosis, go through the signal intensity on T2, go through the diffusion, go through the post-contrast enhancement, and try to reach a differential diagnosis. And don't forget to correlate with tumor marker, and don't forget to talk about the important negative findings. So as I told you, this turned to be dysgerminoma. So by that, I would like to thank you all, and I would be happy to receive any questions from your side.
طيب السلام عليكم ورحمة الله وبركاته. أنا الدكتور عمرو السندي الأورجنايزر حق البادي ايميجينج فور ذيس اكاديميك يير. أول شيء أحب أشكر الدكتورة نوف، الله يعطيك العافية as usual charming وتتعبي من بعدك.
الله يكرمك، جزاك الله خير دكتور.
الله يبقيكي. وبالنسبة للريزيدنتس أنا I know that في تقريبا عدد كبير من الريزيدنت they didn't have the chance إنهم to join us في الليكتشر اليوم because of the technical issues we had at the beginning. I wish إنه اللي حضر يعني he can pass the information for those who did not come. إن شاء الله in the future we'll work on this matter والمحاضرات الجاية تكون أحسن بحول الله. So it's open for questions now. If anyone want to ask any question, he can turn on the mic or type it in the chat.
So there is one question, but I don't understand. In ultrasound, how can I differentiate between sagittal and transvaginal? So looking at the image, so if you can see from the probe itself, if the white, the anterior aspect of the probe is narrow, it is transvaginal. If it's wide, it is transabdominal. Usually when you have a transvaginal ultrasound, the urinary bladder is usually empty. So there will be no urinary bladder fluid, unlikely to get fluid. In cases of transabdominal ultrasound, we always ask for a full bladder, so you will be able to identify the uterus very well. The diagnosis of the last case was dysgerminoma. Any more questions, guys? So regarding the PDF slides, I do apologize, guys. I don't usually give the slides, so I'm sorry about that. Another question, what are the lesions that should not be biopsied? So generally speaking, ovarian lesion, adnexal lesion, we don't biopsy them at all. Endometrial, endocervical lesion, we usually biopsy them to give the diagnosis. So another question, how can we differentiate benign from malignant lesion based on the pattern of enhancement? So generally speaking, this is important for endometrial lesions. So if you have an endometrial based lesion, most of the malignant endometrial lesion, they're usually hypovascular in comparison to the rest of the uterus. Endometrial polyp tend to be hypervascular, so this is helpful in differentiating. Can you please repeat the clinical diagnosis in endometrial cancer clinical staging? So as I said, endometrial cancer, it is usually staged clinically or not clinically, surgically. Surgically means the patient has to go regardless of our MR staging for hysterectomy, bilateral salpingo-oropharyngeectomy, retroperitoneal lymph node dissection, omental resection to know exactly what is the final staging. We do staging with MRI just to help them to know exactly what is the stage in cases of stratification. As I told you before, that these cases, if the patient has multiple comorbidities and they don't want to do a lymph node dissection, if I tell them it is stage 1A, then it means that this patient doesn't necessarily need to go for lymph node dissection. Okay, guys, so I guess we can stop. No more questions.
طيب, okay, I think we can end now. Thank you again, Dr. Anof. It's always a pleasure to have you. أشكر جميع الحضور.
Thank you so much, Amr, for the organization. And looking forward to see everyone, inshallah, soon.